Yeah, good morning, everybody. The first interactive session is on cardiology. It's a privilege to introduce my batchmate as well as my co-registrar, Dr. Suresh Kotegoda. He is a consultant cardiac electrophysiologist, Sri Javadhanpura General Hospital. Over to Suresh.
Good morning, ladies and gentlemen. Congratulations on excellent session so far. I'd like to thank the President and the Council of the Ceylon College of Physicians for the kind invitation. It's indeed a pleasure and a privilege. Ladies and gentlemen, my task is to talk to you about a few ECGs. This is a case one. 68-year-old gentleman who came to us with progressive shortness of breath. He has gone to GP first, and with who diagnosed quite rightly a bradycardia. And as the patient had symptoms, started on salbutamol, oral salbutamol. This is the ECG that was taken before the salbutamol was started, the first ECG. Let's have a look. And any patient who coming with bradycardia, heart rate less than 60, first thing to look at is to see whether P's and QRS complexes are one-to-one. What is more, P's or QRS complexes and their association, or whether there's any dissociation. Easy. So what is the diagnosis here? So we have given the MCQ. Is it a first degree heart block? Is it a second degree heart block, which is Morbitz type 1? Or is it a Morbitz type 2? Or is it a third degree heart block? So I think we'll be voting now. You'll be given a few seconds to vote. Is the time's up? Oh yeah, the results have appeared. Sorry. Yes, indeed, it is second degree AV block, Morbitz type 1. Yes, so that is indicated by the gradual prolongation of the QRS complexes. If I can go back. Yeah, if I can, yeah, gradual prolongation of the QRS complexes, which we see, followed by 1P suddenly goes missing. So a few things about this patient was symptomatic, progressive dyspnea symptoms. So we know that it is a pathology, because this pattern can appear in very physically fit individuals as well. Young patients, very young patients, adolescents, trained athletes, elite athletes, people who are in forces, who does a lot of cardio. This can be normal, but if they are asymptomatic, you clear them. So this patient was, as I said, started on salbutamol, and 3 days later, a patient got admitted to our hospital like this. So he had an episode of loss of consciousness, and when we did the ECG immediately, and this is what we saw. So this is what is known as as we all know, is a pause, and we see why when there's a pause, what we have to see is what is happening during that gap. Is there any activity that is noticeable in that gap that we are seeing? So what is the diagnosis here? Are the ECG lead got dislodged? Is it a second degree AV block, this time Morbitz type 2? Is it a sinus arrest? Or is it atrial tachycardia with third degree AV block? We'll be more voting. So this is the answer. Sinus arrest. 65% have voted for sinus arrest. But 1/3 have actually voted for the correct one, atrial tachycardia. So that is precisely the reason that I mentioned. We need to look at what is happening during the pause, if we can get rid of that thing. Yeah, excellent. Thank you. So during the pause, can you see there are some waves? It's wavy, isn't it? It's not completely flat. And it is not artifact because it is fairly similar. These waves are very similar to one another. Amplitude is the same. So this is actually an atrial tachycardia. It indicates atrial activity. These are P waves, whole lot of P waves which have come through. And so this, what has happened is salbutamol caused an atrial tachycardia. And we all know the AV node, the more you bombard it with activity, electrical activity, more stubborn it will become. And this salbutamol is not really able to increase the AV nodal activity that much, particularly if it is infrahisian block, but it does give rise to increased atrial activity, which means actually this is called the AV nodal paradox. This uh, we might start salbutamol, but actually it's likely to do more harm than good for these patients. It is different if it is sick sinus syndrome. Sick sinus syndrome, even though we off label, we can give some salbutamol as a stopgap measure until the patient gets a pacemaker, if the patient is symptomatic. Uh, but AV nodal disease, this is likely to cause more harm. So we move on to the next case. It is a 58-year-old lady came to the emergency with increasing dyspnea of exertion over a period of 2 months duration, 2 months, and she had a normal physical examination except for a heart rate of above 100, pulse rate above 100, and I can tell the blood pressure was 110/70. And this was the ECG that was taken. Physical examination was normal. So then we come to a tachycardia ECG, slightly increased heart rate, going at about 100. There are quite a few things, a few peculiar things. Then I can tell you this was not a particularly obese lady, was not a normal build. So, it is important to appreciate the morphologies of these QRS complexes also. And so what is the diagnosis? Is it a supraventricular tachycardia? Is it inappropriate sinus tachycardia? Anxious lady? Is it a pulmonary embolism? Is it pericardial effusion? So we are voting. Excellent. Pericardial effusion. So that's very reassuring to know that everyone has appreciated the fact that there's marked electrical alternance in the QRS complexes. In the QRS complexes, as you can see, it is. I want you to look at the right side of the slide where you see QRS complexes are short, tall, short, tall, short, tall. Can you see? It's called electrical alternance. This is as a result of heart bouncing around inside the pericardial sac filled with fluid, and it bounces. When it bounces around from time to time, it comes closer to the chest wall, and the other times it moves away from the chest wall. So hence the change in the amplitude, and overall amplitude is also low amplitude. For a person who is not particularly obese, this ECG shows low amplitude. And also what is diagnostic of this is as can you see the QRS morphology, the amplitude change is particularly profound in chest leads rather than the limb leads. Limb leads also you can see it, but it is profound in chest leads, V1, V2, V3. That's where the heart is directly underneath the chest leads. So the changes are much more profound. And this patient blood pressure was normal. That doesn't mean anything because this has been accumulating over a period of many months. So there's no tamponade. So patient will compensate, but they become later on it found to be tuberculosis. So So this is the important thing. So it is diagnostic, so important not to miss this. This is a picture of a pericardial effusion, chest X-ray, increased cardiothoracic ratio with that kind of peculiar enlargement of the cardiac shadow. The next case, it is a 28-year-old gentleman with recurrent episodes of palpitations. What is the diagnosis? So this is again a tachycardia, wide complex. For a wide complex tachycardia, it is not that wide. That much I can tell you. It's not that wide, but it is wide. It's tachycardia, not very fast. It will be going at about 155. And this is a 28-year-old gentleman, and he underwent an echocardiogram which showed a structurally normal heart. This happens in episodes. He's from Gaul. So what is the diagnosis? Is it a SVT with a right bundle branch block? Is it a right ventricular outflow tract VT? Is it a left ventricular outflow tract VT? Is it a fascicular VT? Fairly split between the so a lot of them have chosen SVT with a right bundle branch block, and 30% have chosen fascicular VT. Let's have a look at that ECG. Something that must not be missed. I'm afraid I don't have a pointer. Can you see the first beat from left? It is a sinus beat. It is a sinus beat, narrow complex beat, and then in the right side, can use the mouse. Yeah, one second. Oh, it went all haywire. Sorry. Yeah. Yeah. All right. Okay. Can you see the arrow? I can see the arrow in my. I'm afraid not. So, so then I want you to look at the first beat at the extreme right, and then the fourth beat at the extreme right, and then the seventh beat from the extreme right. So so those two are narrow complex beats, aren't they? And then those two are actually fusion beats. The one which is at the extreme left is a capture beat. It is quite narrow, and that is a sinus beat which has come through, because these VTs occasionally they are not perfect arrhythmias. They can occasionally just momentarily stop, and at that time, this is a young patient, very young patient, will get a sinus beat coming through, which is from the atrium to the ventricle. And the other beat that I'm mentioning, which is slightly wider, but it is not as wide as the VT beat, which is the fourth beat and the seventh beat from right side. That is a fusion beat, where a sinus beat has also come through, and which has collided with the ventricular ectopic, VT, and given rise to fusion beat. So this is diagnostic of VT. So this itself exclude a ventricular tachycardia. So, and the other thing is, there are a whole lot of long, exhausting lists of criteria to differentiate SVT from VT. But I can tell you, look at the AVR. If the AVR is tall, if the AVR is positive, if you say, look at that and you say VT at the exam, 75% of the time you are going to be right. I think those are pretty good odds, I think, for looking at just one lead. 75% you are going to be right, AVR, if the AVR is positive. Even if this is slightly narrow, I accept that. This is a normal heart VT. And the why I'm harping about this is actually a curable VT, and this is very common. And the reason I mentioned that it's from Gaul is that it is like a epidemic in the down south area. We get a lot of patients from that area, and this is easily can be curable. And so we have then what is the next last question? What is the treatment? Implant and ICD, radiofrequency ablation, is it verapamil? Need more information before I start treating this patient. Yeah, so I'm happy that a lot of people have suggested radiofrequency ablation, which means more work for me. Certainly no ICD. We are not going to give an ICD to a patient with normal heart with a curable VT. And this is actually also known as a verapamil sensitive VT. So actually young patient, we certainly don't want to slow him down too much and give him erectile dysfunction by giving a beta blocker. So we would like to give some verapamil. On the other hand, patients do not want to be on verapamil for years and years. They would actually go for, but we do offer them medical management also. But this is a curable VT that can be cured by a radiofrequency ablation. Thank you.
Thank you, Dr. Kovategoda, for that very interesting session. I would like to introduce, ask my co-chair to give the token of appreciation.
The next interactive session is on dermatology. Let me introduce the speaker, Dr. Chaturari Sirivardhana. He is a consultant dermatologist at District General Hospital, Nuwara. It's over to Chaturari.
Thank you very much. I've arranged a series of patients with medical and dermatological significance. So without much further ado, since we are short of time, let's move on to the patients. So the first patient is a 24-year-old farmer who presented with discharging lesions involving his right foot for over 6 months duration. He could not recall any preceding trauma and he was otherwise well. So you may be able to appreciate there are some active sinuses which are discharging and multiple old healed scars. So this was his X-ray, the X-ray of his foot. You can see a sclerosis of the bone as well as multiple lytic lesions and a distortion of the normal bony architecture of the involved area. So this is the histology. You can see a diffuse infiltrate of leukocytes and these eosinophilic bodies. So time to start voting. Click the button. Is this chronic osteomyelitis, TB osteomyelitis, foreign body granuloma, or mycetoma? So time to start voting. Yes, it is a mycetoma. So mycetoma is actually a chronic infection either caused by fungi when it's called eumycetoma or by bacteria, then it's called actinomycetoma. And it can involve the skin, the underlying structures and bone. And it can be quite disfiguring, especially in advanced patients. Sometimes it can even lead, we may have to treat by amputation as well. It's common in people who work outdoors like farmers. So the next patient is a 40-year-old lady who presented with this rash, asymptomatic, for 1 year's duration. You can appreciate the dusky coloration, mild scaling, and then network-like retiform pattern on the skin. So what is the diagnosis? Time to start voting. Is it livedo reticularis, erythema bignay, vasculitis, or cutis marmorata, telangiectasia, or paniculitis? Yes, actually, the clue is I'm from Nuwara. So actually, this is erythema bignay, which means erythema caused by fire. Basically, in cold climates, especially it was common in the West before the advent of central heating when people use hot water bottles. People use local infrared thermal radiation to warm themselves. This causes damage to the superficial capillaries, red cell extravasation, and hemosiderin deposition. So this is what we call erythema bignay. It's a pre-malignant condition with prolonged exposure to heat. You can develop squamous cell cancer as seen on this gentleman's left foot, as well as Bowen's, you can see the scaly plaques on his right foot. So why I put it for here is because this can sometimes be seen in people with cold intolerance. This gentleman was brought by his wife saying that it's difficult to get him off the stove. He's always near the stove. So this patient actually had hypothyroidism. When we checked, he had a TSH over 100. So erythema bignay can be caused rarely by hypothyroidism as well. So the next patient is a 76-year-old lady who presented with this rash. You can see it as a parasagittal involvement spreading right from the nose up to the scalp. There is evidence of ulceration and pigmentation and even exaggeration of skin markings due to lichenification. So what is the investigation of choice of this patient? Would you do a skin biopsy or check for leprosy? The patient also had a sensory dysesthesia, an MRI of the brain. So time to start voting. So you can go back to the picture actually to have a look. Yes, so a lot of people have voted for slit skin smear for leprosy. Actually, this is a variant of what we call trigeminal trophic syndrome. Now, typically trigeminal trophic syndrome involves the ala nasi. It spares the tip of the nose. This is similar to the phantom limb phenomenon we see after a limb amputation. This is due to some form of damage to the trigeminal nerve, either the nerve trunk, the Gasserian ganglion, nerve nuclei, or some lesion in the cerebellopontine angle. We commonly see it after CVAs as in that previous patient or due to neoplasms. Even in this gentleman, you can appreciate he also has a lesion on his scalp. So it's usually paramedian and spares the tip of the nose, which has a innervation by the anterior ethmoidal nerve. So it's important not to miss anyone having a parasagittal lesion, especially involving the ala nasi. This is another patient. You can appreciate the radiography where you can see a lesion in the CP angle. Next, we have a 14-year-old boy with a history of poor school performance and focal seizures since early childhood. This is a relatively easy one, I hope. So you can appreciate there are multiple nodules and papules involving his face and a large plaque on his forehead, a forehead plaque. This lesion was there on his lower back, a dermal plaque. So time to start voting. What is the diagnosis? So Sri Lankans generally do like to vote. So I hope you all also will be enthusiastic and vote for all the questions. So this is tuberous sclerosis. So these lesions are called adenoma sebaceum, which are hamartomatous lesions. And the presence of a forehead plaque is indicative of more severe neurological involvement. So they have, this is called a Sjogren's spot. So they have development of multiple hamartomatous growths on the skin and other organs like this periangle fibromas. Then they can have ash leaf macules, confetti-like hypopigmented macules. They develop renal angiomyolipomas, cardiac rhabdomyomas, and cortical tubers. This is due to a defect in the hamartin or tuberin genes. Unfortunately, there is no specific treatment. However, sirolimus or rapamycin shows some promise in the treatment of these hamartomatous lesions. So this lady came with this asymptomatic plaque, which is progressively enlarging. You might appreciate that there are multiple satellitic lesions elsewhere. I don't know that you can see my arrow elsewhere as well. And a close-up shows that it's a red fleshy plaque with multiple satellitic lesions. So we did a biopsy, which showed a very dense infiltrate of lymphocytes and plasma cells. Since she was from Dambulla, we checked for leishmaniasis. There was no evidence. There was also no evidence of secondary malignant deposits. The white cell count, these are the abnormalities we saw in it. Please have a look at it. You can see that there is a very high leukocyte count, 42,000, which is predominantly lymphocytic. So what is the most likely diagnosis? I know with the available information, you can't come to a definitive diagnosis as yet, but please start voting. Yes, the results are out. It is leukemia cutis. Now, generally, in leukemia, you can't confirm obviously without immunocytological or bone marrow studies. But nevertheless, in leukemia, we can see cutaneous deposits in all forms of leukemia, from the acute and chronic variants. These have to be distinguished from leukemoid eruptions, leukemids we call them, which are conditions which can be associated with leukomas, like leukemias, like pyoderma gangrenosum, Sweet syndrome, which also can be seen concurrently in these patients. So let's move on. We have a 57-year-old lady with multiple whitish plaques. She was otherwise well and no preceding history of trauma. These lesions were hard, whitish, and asymptomatic. So what do you think is the diagnosis? Please vote. So I mentioned that these lesions are hard and whitish. So that is actually against the diagnosis of xanthoma. This is actually calcinosis cutis. Nice to see a lot of people have got it correct. So next we have a 67-year-old farmer who presented with this rash. It was mainly on the sun-exposed areas of his trunk. If you look at a close-up, you'll see most of the skin is normal except for this annular cord-like structure. And he was otherwise well. So what do you think is the diagnosis? This is hard, but nevertheless, pick a guess. Please vote. Yeah, usually in pellagra, although it is photosensitive, the lesions are much more scaly. You won't get a cord-like serpiginous margin like this much. But the diagnosis here is what we call actinic granuloma. The importance is actually 40% have concurrent diabetes. Even this patient, although who was not a previously diagnosed diabetic, he was found to have a very high blood sugar. So if you see anything unusual like this, it's always better to refer to us. Next patient was a 67-year-old farmer who presented with soreness of his mouth and difficulty in opening his mouth and protruding his tongue. He was an avid beetle chewer. You can probably appreciate the beetle stains. And this is all he could protrude his tongue. What is the possible diagnosis, probable diagnosis? Please vote. I'll give a clue. This is actually a pre-malignant condition, and it's very common among beetle chewers. Hence, it's very common in the subcontinent. You all probably are aware that we have a disproportionate number of oral cancers. So this is what we call submucosal fibrosis. This is due to the chemicals in the areca nut and the shunam, as well as the tobacco, which causes low-grade inflammation and fibrosis. So this is a more severe patient. You can see leukoplakia and loss of papillae of the tongue. And this will progress on to develop complications like erythroplakia and squamous cell carcinoma. So it's important to detect it early. So this 9-year-old girl was referred to us from the pediatrics. She came in a wheelchair for the treatment of her viral warts. You probably can appreciate the viral warts on her hand, left hand. And she had a few warts on her face as well. I don't know if you can see. You can appreciate her eyes as well. Her sclera, although there are dilated blood vessels, sclera is white in contrast to conjunctivitis. So which of the following is false? First of all, what is her condition? Yeah, so if you go back, you can start voting actually. Please do start voting. we noticed that she had a typical posture. She was slouched forwards, and her head was also turned forwards and tilted to a side due to hypotonia. She almost showed that she's not showing much enthusiasm and not paying attention. And she's supporting herself by her upper limbs. So this is ataxia telangiectasia, which is one of the common causes of combined or mixed immunodeficiency. So it is an autosomal recessive condition, and due to the immunodeficiency, treatment is actually a challenge. And although they are prone for sinopulmonary infections, they have a high risk of leukemia and lymphoma, so we don't expose them to unnecessary radiation. So that is what is false actually. And even heterozygotes of this gene have a high risk of breast cancer and leukemia. And they have high levels of serum alpha fetoprotein. So this will be the last patient, 24-year-old female who complains of progressive hollowing of cheeks. You can see there is hollowing of her cheeks. It's bilateral, almost symmetrical. She was otherwise well, and this was going on for several years now. So this is not exactly a quiz, but what do you think is the diagnosis if you go back? Sorry? This is actually partial lipodystrophy, right? So one thing we need to exclude is morphia, which also can cause hollowing of the face, but what we call Perry-Romberg syndrome of facial morphia. This is one of that. You can see, however, unlike lipodystrophy, which only involves the fat, here there is scarring, loss of lip substance, and it can involve the cartilage and bone as well, and it's unilateral. So regarding lipodystrophies, please, if you could be kind enough to vote for this. Which of the following is false? So generally, lipodystrophy we divide as generalized and localized, and hereditary or familial and acquired. So that patient had acquired partial lipodystrophy. Yes. Okay, so basically there is no voting for this apparently. So in this patient, just note regarding lipodystrophy, it can be caused by both HIV as well as HIV treatment with protease inhibitors. And especially when the disease is generalized, they have lower leptin levels due to reduced fat, and they have high risk of developing metabolic syndrome, fatty liver, chronic pancreatitis, and even they can go on to develop other complications as well. So type 2 membranoproliferative glomerulonephritis can be seen in up to 20% of patients, but that takes typically 8 years to for the onset, after the onset of the lipodystrophy. So it's important to follow them up. They can even develop it even a decade later. And they can have compensatory fat deposition in other parts of their body as well. So I think that's all we have time for. If you have any questions, I'll be happy to have it either during the tea break.
Thank you, Dr. Sirivardhana, for that very interesting session. Please accept our token of appreciation.
The next interactive session is on radiology. It's a pleasure to introduce the next speaker, Dr. Lakmali Paranheva. He's a consultant interventional radiologist, ASIL Group of Hospitals. Over to Lakmali.
Thank you very much. Thank you for giving me this opportunity. So I'll be talking about imaging, and I thought I'll talk about X-ray interpretation. So you're all familiar with chest X-ray interpretation. So when you're looking at a chest X-ray, you have to have a systematic approach. Interpret the X-ray with conjugation with the clinical findings, and always compare with the previous X-rays if you have. So looking at X-ray, what are the things that we see? Proper X-ray will have the mediastinum and the lung fields. The lung fields will be, you have to compare the lung fields with each other. The hard borders are made by, the right hard border is made by the right atrium, and the left hard border by the left atrium and the left ventricle, the pulmonary trunk and the aortic arch. And there are some important lines, the trachea, the trachea, the bronchi and the costophonic angles, the diaphragmatic surfaces, and the pleural lines has to be looked for systematically. And what are these lines? The right paratracheal line is very important. It has to be seen as a single line. The zygoesophageal line, the para-aortic line, the paraspinal line, and single lines for the hard borders, the diaphragmatic margin, the costophonic angles has to be seen. And the heart cardiothoracic ratio can be assessed, and the bones of the chest has to be seen. So when you're looking at an X-ray, main thing is you have to see whether it's a PA versus a AP wave. All those things that we see in a routine X-ray, we are commenting on a routine PA wave. So make sure that you're looking at a PA wave rather than AP or a supine wave. Look at the inspiration. You have to see 10 posterior ribs above the level of the diaphragm to interpret a X-ray correctly compared to a expiratory wave, which will show the mediastinum widened and so on. And see the penetration, the posterior vertebral bodies should be seen vaguely through the cardiac shadow. Whereas this you can't see the spine through the cardiac shadow, whereas here you can see it very well, as opposed to a well penetrated X-ray where the spine vertebral bodies should be seen vaguely through the cardiac shadow. So all these things has to be there to interpret an X-ray well. So the rotation, the X-ray has to be well centered. You have to see whether the spinous processes are of equal distance from the clavicular ends, as in this image, whereas if it is rotated, all these lines will be widened and you cannot interpret an X-ray accurately if it is not well positioned. Then you have to look for the hidden areas, the APCs, the hilar, the retrocardiac shadows, and the subdiaphragmatic regions. The normal hilar will be seen as concave margins with concave margins, whereas if it is convex like that, and the widened paratracheal stripe, as in this X-ray, it will be indication of lymphadenopathy. Also, if the lines, you have to see whether all the lines are seen clearly. You can see in this patient, there is a double line to the right heart border. As you all know, it indicates that there is a left atrial enlargement. Another important sign I need to tell you is a silhouette sign, where it enables you to find where the pathology is located in a chest X-ray. The reason behind is a substance of same density which are in contact with each other cannot be differentiated. So there's an opacity in the retrocardiac region here. If the heart border is seen separately, that means it is in contact with the heart, as compared to this one where the heart border is seen and it is not in contact with the heart border. So this patient has an opacity in the right lower zone of the left hemithorax, and the left heart border is not seen. So the diagnosis would be a lingual lobe lesion rather than anything else. Or here the same situation, similar opacity, but the left heart border is seen very nicely, indicating that it is not in contact with the heart, either posteriorly or anteriorly. So this is a lower lobe consolidation. So I will start some questions. So this is an X-ray of a patient, young girl who presented with shortness of breath. Right, so it's very clear. There is the lung margin is collapsed. There is a lucent area there. There is a pneumothorax. But then you have to see whether what is happening to the mediastinum. Is the trachea central? Bronchi are there. The heart is in normal position. So it's a simple pneumothorax. Second patient, a critically ill patient in ICU suddenly developed difficulty in breathing. Supine X-ray. What do you think? Right. So it is a pneumothorax. So this is, you see a deep sulcus there. So you can compare the two lung fields. This is loosened compared to this side. The right side is loosened compared to the left. So we have to see whether which side is abnormal. Then you see the deep sulcus sign there and less lung markings on this side. So it is a pneumothorax. But still the trachea and the mediastinum is slightly shifted towards the other side. So again, similar patient following trauma. There is this is a chest X-ray of the patient, and what is the diagnosis? You can, sorry, vote. Yeah, again, it's a pneumothorax, but then again, you can see that the diaphragm is pushed down, the mediastinum and the trachea are deviated towards the left. There is a large area of air lucencies there, so it's a tension pneumothorax. Sorry, so this is also somewhat similar X-ray of a patient who presented with difficulty in breathing. Right, what is the diagnosis there? Right, so it's correct. So you can see as compared to the previous X-ray, there is now, compared to this X-ray, you can see the lung markings through the, sorry, you can see the lung markings through the lucent area, and the mediastinum is shifted towards the other side. Heart is shifted, trachea is shifted. So it's due to complete collapse of the left lung rather than a pathology of the right lung. The mediastinum, and there is herniation of the lung towards the left hemithorax as well. Sorry, okay. Right, so this is an X-ray. You can, I think, vote for this also. What is the finding? You can vote for this. Yeah. So it's there is emphysema here as well as a pericardial effusion. Pericardial pneumopericardium. There you can see a line there where there is a small pneumopericardium as well as some gas lucencies within the mediastinum extending to the neck. So the lung fields are normal. Rest looks all right. Sorry about that. Again, another X-ray. What is the pathology there? You can vote for this. Sorry, it's not moving. This is going on its own also. Right, okay, so I can go back now. Okay, this is the one. You can vote for this. Right. No, it's again, yeah. Okay, you can vote for this. Yeah, so you can see gas under the diaphragm. Rest of the X-ray looks all right. There are gas lucencies under the diaphragm. So these are the areas you have to look for very carefully when you are looking at a chest X-ray. Next patient, patient with fever, chest X-ray, typical finding of. You can vote for that. I'm so sorry. This is moving on its own. Right. So it's a typical appearance of a consolidation limited by the fissure. There is air bronchogum. There is the trachea is central. So it's a consolidation of the right upper lobe. So look for the pleural, if you look for costophrenic angles, pleural effusions of this patient. Another patient with a all right, okay. So this is a, you can't poll for this. So this is a well-defined opacity in the mid-zone of the lung. You see some air lucencies on top of it, but it is a most likely a mass lesion. So this is another patient, similar opacity, but there is a air fluid level in it with a slightly thick wall. So it's most likely an abscess, but a cavitating neoplastic lesion also has to be thought of. Sorry. So this is another patient with an opacity. I hope you can see there's an opacity there. So which my question was, where was the abnormality? So as I told you before, if it is in contact with the heart border, you can't see the heart border separately. So it's a consolidation or a lesion in the mid-lobe rather than posterior or anterior. This is very straightforward. There is obliteration of the costophrenic angle with opacification of the lower zone. It's a pleural effusion. The diaphragmatic margin is not seen. Costophrenic angle is not clearly seen. And last patient, again, there is cardiomegaly. Obviously, the heart is enlarged. There is opacification of the perihilar region with a bat wing appearance, and there are curly B lines. No pleural effusion. So this is most likely a patient with pulmonary edema. So that's all I have. I hope it was of use. Thank you very much for inviting me for the talk.
Thank you, Dr. Paranaheva. It was very interesting. Please accept our token of appreciation.
The next is our last interactive session. This is on choosing an antimicrobial. It's a pleasure to introduce the speaker, Dr. Lilani Katanayake. She is the consultant clinical microbiologist, Medical Research Institute. Over to you, Dr. Lilani.
Good morning, and I would like to thank the President and the organizing committee for inviting me for this very important annual academic sessions. So this week has been declared as the Antimicrobial Awareness Week. So my first slide, I would like to dedicate my first slide for this, to make you aware on AMR. So WHO declared AMR as one of the top 10 global public health threats. So if we don't address now, drug-resistant diseases could cause 10 million deaths each year by 2015. So main drivers in the development of drug-resistant pathogens are misuse and overuse of antimicrobials. So to combat AMR, we have to have a united multi-sectoral approach, and we should use the existing antimicrobials wisely and responsibly rather than waiting for new arrivals. So moving on to my first case scenario, a 42-year-old previously healthy lady married with two children admitted to a base hospital and complained of fever of 4 days, loss of appetite, vomiting, loose stools. Her urine output was normal, and there was no recent medical or surgical history. On examination, she was afebrile, ill-looking, hemodynamically stable, and with a clinical evidence of right-sided pleural effusion and right upper quadrant abdominal tenderness. So the clinical team made a diagnosis of dengue fever in critical phase. So my first question, please vote regarding the empiric antimicrobial therapy for this patient. Whether you use meropenem, cefuroxime, cefotaxime, vancomycin, or no antibiotics. Excellent. So why are we not giving any antibiotics? Because the patient is previously healthy. There is no recent history of hospitalization. She was afebrile and stable. And the clinical team has made a more suitable clinical diagnosis. So answer is, and no antimicrobials. The patient was managed as follows. She was catheterized, temperature chart was maintained, fluids were managed, and she was given IV meropenem 1 gram 8 hourly, and blood culture was taken before starting antibiotics. So her UFR, CRP, and serum creatinine came as normal. Platelet was low with a high PCV, and the fast scan showed evidence of bilateral pleural effusion and acidic fluid in upper and lower abdomen, and NS1 antigen positive, confirming the clinical diagnosis. So during her stay in the ward, meropenem was continued in spite of normal CRP. So on day 5, she developed fever spikes while on meropenem. Blood and urine sent for culture, and antibiotics were changed to ceftriaxone 2 grams BD and doxycycline 100 milligram BD. She was given a blood transfusion, and urinary catheter was in situ. So fever was spiking. Now it's 102. CRP and full blood counts rising. IV line inspection, there was no significant finding. Echocardiogram was normal, except for mild MVR, mitral valve regurgitation, and with no evidence of infective endocarditis. So they plan to start piperacillin tazobactam. But the patient left against medical advice. So the microbial investigations at MRI, we got urine culture report as mixed growth, and the automated blood culture signaled a growth, and we identify the culture as Enterococcus faecium. But when we informed, the patient had left the hospital. So so she got readmitted to a general hospital on the same day, day 9 of illness, with unresolving fever. So on examination, she was ill, febrile, pale, with a cardiac murmur and hepatomegaly. So that team made an diagnosis, dengue hemorrhagic fever in recovery phase, but raised a suspicion of infective endocarditis, and 2 blood cultures were taken. So my second question, please vote. What is the most suitable antimicrobial therapy? Whether it's penicillin and gentamicin, or ceftriaxone, meropenem and vancomycin, vancomycin and gentamicin, or piperacillin, tazobactam and vancomycin. So she had a recent hospitalization. An intravenous catheter, urinary catheter, had been for a longer period. So we have to suspect secondary bacteremia. And they have suspected infective endocarditis as well. And there are no microbiological reports, so we don't know whether it's endogenous or exogenous strains. So meropenem also have been given. So at this moment, you have to go for broad spectrum antimicrobial cover for this patient, because we don't know what's going on, what is the organism. And since meropenem has been given, I would prefer piperacillin tazobactam and vancomycin on this patient. Patient was started on IV meropenem and vancomycin because this clinical team did not know that the patient had been given meropenem. Blood picture had secondary bacterial infection following viral infection, and TOE had shown tricuspid mass, confirming the diagnosis, and CRP was high. So at General Hospital, blood cultures came as no growth because the patient has been given many antibiotics. So they started to trace the previous blood culture. And this is the antimicrobial susceptibility test result of this organism. It was beta-lactam resistant, but glycopeptide sensitive, and gentamicin synergistic test was susceptible. So you can combine gentamicin with glycopeptides if you wish so. So my question number 3, what is the best antimicrobial regimen? Is it linezolid, high dose penicillin or ampicillin, or vancomycin, gentamicin, or vancomycin, pip/tazo? Please vote. Linezolid and daptomycin are red light antibiotics, so you should use cautiously and safe for resistant strains. There are beta-lactam and glycopeptide resistant strains. Even in Sri Lanka, we do. It's not uncommon now. Vancomycin resistant Enterococcus faecium is common. High dose penicillin, ampicillin, you know that we are already giving the highest dose as the standard therapy, so it is of no use. And if it is resistant, no place for combinations. vancomycin and peptazo. Now, piperacillin tazobactam or any high-end antibiotic can be given if you suspect a co-infection. Otherwise, my answer also would be vancomycin and gentamicin because we have a microbiology report. So what are the lessons? Unnecessary antibiotic use, misuse, also overuse may increase chances of hospital-associated infections with resistant strains. Now, they have, most of you all know about meropenem. It's broad spectrum antimicrobial, but you have to use or you have to save that only for life-threatening situations because this antimicrobial doesn't have a spectrum of activity on Enterococcus faecium. So what has happened in this patient was at the first encounter, they have given meropenem and it has eliminated all the endogenous or susceptible flora and augmented selecting E. faecium. Also, trace evidence of previous antimicrobial therapy and microbiology reports when you decide on antimicrobials. Also, revise the antimicrobial. Coming into case 2, this is a 40-year-old previously healthy male presented to a surgical ward complaining of fever and chills. My presentation is, yeah, right. So on examination, he had high-grade fever of 102 degrees. He was very ill and right lower limb cellulitis with an erythematous rash. He did not have diabetes mellitus or any comorbidities. So this patient was immediately started on IV benzyl penicillin and cloxacillin. But patient continued to deteriorate rapidly with low blood pressure and tachycardia. So the surgeon transferred this patient to ICU, referred to a physician, and blood cultures were taken. Now at the moment, patient in septic shock. So the team diagnosis was cellulitis and septic shock. So what is your question 4, the last question, what is the most suitable antimicrobial regimen? Please vote. Yes. Now, cellulitis, the differential diagnosis, you have to know, there are 3 common differential diagnoses. It could be group A Streptococcus cellulitis or community acquired MRSA skin and soft tissue infection, or it could be necrotizing fasciitis. And the organisms will be Streptococcus, including group A, Staph aureus, including community acquired MRSA, Pseudomonas, or any gram-negative bacilli, or anaerobes and anaerobes. So you have to cover all these organisms. Then you have to know your local epidemiology of skin and soft tissue infections. What is the prevalence of these infections? Also, when you are going for deciding on antimicrobial, you have to know the severity of illness of the patient. So appropriate spectrum of antimicrobials should be given. It should be vancomycin and meropenem. So the blood culture report came as methicillin resistant Staphylococcus aureus, which is a beta-lactam resistant, but non-beta-lactam sensitive. So this is the common test results that a community-acquired methicillin-resistant Staphylococcus aureus will give versus hospital-associated strain. It's here. We do have community-acquired Staph aureus. It was 21% in 2016, and we do see commonly in our laboratories. Usually, skin and soft tissue infections are the commonest. And young adults and median age around 40-45 are the common age group they will have. Vancomycin can be used for systemic illness, but clindamycin can be used for if it is local. So what is antimicrobials in sepsis? There is no single best regime. You have to consider site, you have to consider the organisms causing infection, the local resistance pattern, then the appropriate spectrum, and you have to give antibiotics quickly and empirically at appropriate dose and revise the regime. These are the common antimicrobial mistakes: failure to start early, failure to review previous lab results, failure to take into account previous antimicrobial usage, and failure to revise timely. So the last slide. Now, this is the checklist for selecting antimicrobials for empiric therapy. You have to look for age of your patient, recent hospitalization, and you have to have an awareness on local epidemiology of infectious diseases like emerging infections and organisms, and the local antimicrobial pattern. Again, then positive organisms and the severity of illness. And always trace the microbiology reports. You review your antimicrobials and revise the antimicrobials. Thank you very much.
Thank you, Dr. Karunanayake, for that very interesting session, as well as giving important messages about antimicrobial use. My co-chair will hand over the token of appreciation.
Now we have come to the end of the interactive sessions. On behalf of the Ceylon College of Physicians, I would like to thank all 4 speakers for their wonderful presentations. And I hope that the audience as well as everybody has enjoyed with polling and while gaining knowledge. Thank you.